Bismillahirrahmanirrahim. I am Dr. Hasib Alai. Currently, I am working as assistant professor of orthopedics and spine surgery at Shalamar Hospital and Shalamar Medical and Dental College. Today, I will be discussing about the neck trauma, which has very much importance with regard to the ATLS and how to manage the primary spine trauma. Trauma to the neck and spine is a very life-threatening, and often it is misdiagnosed because of unconsciousness at times with the patient and due to low GCS as described previously, and missing the spine injuries, especially cervical spine, is very devastating and life-threatening because cervical spine carries very important structures pertaining to the life, and always there should be low threshold to suspect the cervical spine injuries. Always suspect cervical spine injuries in a head trauma with unconsciousness until proved otherwise. And there are certain protocols which we will be discussing in further slides, how to diagnose and how to make this diagnosis accurate and for better patient management. Why cervical spine is very much important? Let's have some discussion about basic cervical anatomy. Usually cervical spine comprises of 7 cervical vertebrae acting as a protective conduit for vital structures like spinal cord, vascular structures, esophagus, and trachea, airway, breathing, circulation. Basically, the ATLS basics, air, ABC, is vitally present in the neck area. So, usually there are 7 cervical vertebrae, and cervical spine is further divided into the upper cervical spine and lower cervical spine. Lower cervical spine is also called subaxial cervical spine, and the upper cervical spine is very much important with regard to the pediatric age group because of integrity of the upper cervical spine is mainly dependent on the ligaments like transverse ligament, which is very much important for C1, C2 articulation, and Euler ligament, which is important for the atlanto-occipital articulation. So in pediatric age group, it is very much important to rule out any cervical spine, especially upper cervical spine injuries in case of head trauma or any sort of trauma leading to the unconsciousness or altered sensorium. Basic aim is to protect the airway, maintenance of the clear passage for the breathing, spinal cord integrity, and major vessels like carotid and vertebral arteries supplying the brain. Like cervical spine has vertebral arteries, carotid arteries, which is the main blood supply for the spinal cord and the brain. So any of the trauma leading to the fractures or subluxation can lead to disturbance of the circulation of our central nervous system. Let's discuss the mechanism of injury. Mechanism of injury is very crucial for determining any extent of the cervical spine injury. It can be a low energy falls like in the elderly, or high energy mechanisms in the young patients due to their high strength of the ligaments and osseous structures, and one of the most common in our society is the road traffic accidents or the high impact. Basically, these accelerating and decelerating forces. These accelerating and decelerating forces basically determine the mechanism of injury. Most common injury pattern is the flexion distraction forces leading to the facet subluxation. In the flexion teardrop is the flexion and axial compression, and so on. and falls from the height that often lead to the axial loading. Axial loading may lead to the compression fractures of the cervical spine, compression fractures that are classified according to the AO classification, and sports injuries like high impact injuries like in the soccer, in the hockey, and cricket, ball trauma, and so on. And the most rare form that often lead to the Brown-Sequard syndrome or the anterior cord syndrome, mostly that lead to the vascular insult to the cervical spine, are the penetrating trauma. Penetrating trauma due to the sharp objects or the firearm injuries. Basically, and the injury mechanism is very important with regard to pertaining the extent of the injury, like blunt trauma often lead to the soft tissue destruction. Soft tissue destruction may lead to the soft tissue edema that lead to the airway compromise, respiratory compromise, which is often obvious on the x-rays, like the increase in the paravertebral shadow, which is abnormally if more than 6 millimeter in front of the C2, and more than 22 millimeter if shadow is increasing above the 22 millimeters in front of the C7. How patient presents. High index of suspicion is critical. Even subtle signs can indicate severe injury. Look for the word and the subtle indicators. Localized symptoms. If a patient is alert, he may present with a neck pain, tenderness, swelling, bruising, or visible deformity. Neurological deficit. There may be simple weakness, paresthesia, altered sensation below the injury level. In the neck trauma or any cervical trauma, we have to identify the injury level or the neurological level. Injury level is the level which is the most rostral level in which the damage is maximum, and above that injury there is a normal spine. And neurological level is assessed by the ASIA scoring, which states that neurological level is that level which has highest power of grade more than 3 by 5 above the injury level and 3 by 5 in the major muscles group below the level of injury. And this may be further explained in while we consider the ASIA scoring, which will be discussed later on. Respiratory compromised is the dyspnea, stridor, wheezing sounds, hoarseness, difficulty in the speaking, which I already told you about, which has been suggested by the soft tissue swelling. We should suspect massive soft tissue injury when we see the swelling of the neck. Other signs are the dysphagia, difficult swallowing, active bleeding from the neck, which is most common in the penetrating injuries, expanding hematoma, because neck is very vascularized area of our spine. Initial assessment. Adherence to the ATLS protocol is the foundation of managing cervical spine system. Airway management. Establish the patent airway within line with the cervical protection. And cervical protection is very important, and it varies in certain conditions. Like pediatrics, we have to keep the patient neck away from the flexion. We should avoid flexion to maintain the airway in the pediatric age group because of the high head and neck ratio to the body. And in the ankylosing spondylitis and in the dish diffuse idiopathic hyperostosis of the cervical spine, we have to maintain the airway differently from the normal person because of the anatomy and the pathophysiology of these diseases. Because if we apply a rigid collar like we do in the normal patients, in the ankylosing or in the dish patients, that will lead to the epidural hematoma and will lead to the progressive neurological deficit. So we should avoid the traditional methods in such condition, which is no doubt very rare, but we should keep in mind that we should know how to maintain airway in these patients too. Breathing and oxygenation, access the ventilation and oxygen and provide supplemental oxygen. Circulation, hemorrhage and control, identify and control any external bleeding, ensure adequate perfusion. And fourth part is disability. Disability, as I already discussed, we calculate this by the ASIA scoring in the trauma condition, where the patient is in the spinal shock or in the neurogenic shock, and his GCS, his pupil, and the response motor sensory, all are considered in the ASIA scoring, which is the ideal method for assessing this. And exposure, all the head and neck should be very accessible to see all these kinds of injuries, but prevent the hypothermia, especially in the winters and in the areas where the normal temperature is normally low. Airway management. Given the proximity of the airway of the cervical spine, meticulous management is paramount. Always ensure an unstable cervical spine until definite imaging proves otherwise. C. Spine protection. Employ jaw thrust maneuver rigorously, avoiding any head tilt to prevent further spine injury, and especially in the ankylosing spondylitis dish patients. Intubation techniques. Ideally, there should be fiber optic intubation. Perform rapid sequence intubation with careful inline stabilizer. Consider fiber optic intubation if available. Surgical airway. Be prepared for the emergency tracheostomy cricothyrotomy if the conventional intubation fails or is contraindicated. Now we have done all the ATLS protocol. We will start examining physical examination to see any localized tenderness of the bony prominence like spinous processes, head neck movement, and then we will proceed to the imaging modalities. Basic is the X-ray, but if the patient is unconscious and unable to and have multiple injuries, the ideal protocol is the CT cervical spine in the good trauma centers, which always rule out any of subtle cervical injuries. MRI should be considered suspecting the ligamentous injuries. Common fracture management. The common fractures are, as I already discussed, the cervical spine is divided into the two areas, upper cervical spine and the lower cervical spine, which is also called subaxial cervical spine. Upper cervical spine, ATLS axis, ATLS Jefferson's fracture, Odontoid fracture is the most common in the old adults, and pediatric age group. Hangman's fracture, C2 bilateral pars fracture, which is very unstable fracture. Ideally, imaging CT scan is very necessary before managing these sort of injuries. Burst compression, teardrop fractures, and management, non-operative and operative indications depend on the fracture modification. Wherever is the ligamentous injuries involved, they always need sort of operative intervention if patient's normal hemodynamically stable. The fractures which can be operated non-operatively, like Jefferson's fracture and Odontoid type 1 and type 3 fractures. Hangman fracture, they displace less than 3 mm and less than 11 degree angulation, and burst fracture less than 50% of the compromise. And these can be treated conservatively if there is no neurological loss, but we have to often know of operative interventions like when we have ligamentous injury like transverse ligamentous injury, Eller ligament injury, and the Odontoid type 2 fracture, which is often a watershed area, often needs surgical intervention either from the anterior or the posterior approach. And facet dislocation, which is very common in the flexion distraction injury mechanisms, often lead initially close reduction and then definite with the anterior or either posterior approach, depending on the MRI conditions of having discs or any ligamentous compression or from the posterior side. Prognosis initially of any of the cervical trauma depends upon the severity of the injury and, more importantly, the severity of the neurological deficit. Severity of the cervical cord injury, timelines of the intervention, presence of the associated injury, and effectiveness of the rehabilitation. Early mobilization and prompt definite treatment significantly improve neurological outcomes and reduce complication rates. Thank you. If any questions, you can proceed further.